Welcome to the second part of the pulmonary function test information. So this one, we're going to go into how to do some of the different lung function tests. So we sort of covered in the last one indications and how to look at it. If it was restrictive, what does that mean? If it was obstructive, what does that mean with the numbers? And so if we're going to have low flow rates, that's going to be an obstructive condition, right? There's something obstructing the flow of gas coming into and most importantly out of the lungs. Well, then when we have restrictive, because the lungs are being have a smaller volume, they're a smaller container, if you will, they're not going to be able to hold as much volume. So if someone just has a low volume, that's an issue where it's something restricting their lungs from expanding, whether it's the lung tissue itself or something outside of the tissue, or even something like, hey, the muscles that expand the lungs, like the diaphragm, the external intercostals, those things might have like a neuromuscular issue that cause it to be hard to breathe as well. So when we're looking at restrictive, a lot of our conditions are going to be restrictive, but we do have obviously obstructive diseases, just like we have chronic obstructive pulmonary disease, which is actually a couple of diseases lumped together. So here we're going to talk about how to do some of the different pulmonary function tests. So what we'll try to do, and I want you to look at some of the videos of the test being done as well. I'll give you a audio description of what's going on and a visual as far as here, but I want you to look at the videos in your PeepID website. Log on there, and it actually shows videos of people doing a pulmonary function test. It shows videos of people doing a peak flow meter. It shows videos of people doing a complete pulmonary function exam. So I want you to go on there and watch those videos, especially if you're a visual person. You have to see it before you start diving deep into the material. Then I recommend that you do that now and then come back to this video. All right, let's get started. The slow vital capacity, this is usually the first test in a complete PFT that we do. This one is very, very important. It's done with all complete pulmonary function tests. This one's important because if someone has something that's obstructive, where there's premature closure of the airway, remember the airways get smaller as you exhale. And as they get smaller, especially if there's like a floppy airway like we see with emphysema, it can prematurely close. If you're forcing gas out, if you're blowing out really hard, it could really prematurely close that airway, and you're not going to get a good feel or a good measurement of the volume that the patient's lungs can contain. So the advantage of doing a test where they blow out slowly, and that's the slow part of the slow vital capacity, would be that at nice, gentle, full exhalation will avoid some of that premature closure of the lungs. And so therefore you get a more accurate evaluation if the patient has a restrictive process with their obstructive process. So this is something that's standard. We do it with every complete PFT. And a complete PFT is where we take a patient into the pulmonary function lab, and hopefully you guys get to experience this in school and or outside of school. We take the patient into a pulmonary function lab, and we have that big body box machine like you've seen in the other presentation, and we have the patient breathe on it, and we do all different types of tests, and that includes the slow vital capacity. Here's the thing, we also have patients in the hospital at the bedside, and most of the bedside machines that you can take into the hospital rooms include the capability of performing a slow vital capacity as well. The big advantage of a slow vital capacity, like I said before, and I'll reinforce this here, is that if a patient has an obstructive process, you want to do a slow vital capacity to make sure that their volumes are accurate. Because if there's premature closure, okay, if there's premature closure of the airways with a forced vital capacity and you don't get a slow vital capacity, it may look like the patient has both obstructive and restrictive disorder, when in fact they just might have an obstructive only disorder. So when in doubt, if a patient is suspected of having an obstructive disorder, not only do a forced vital capacity, but also do a slow vital capacity as well. Trust me, you will save yourself a lot of time. It'll help tease out if it's truly a combined restrictive obstructive effect or if it's only an obstructive effect. So the slow vital capacity, when in doubt with someone that has an obstructive disorder, do it, okay? So this is done with almost all complete pulmonary function tests. It's a way to look at vital capacity. So remember that volume box, right? We talked about that in the last presentation, and we did it in pulmonary A&P as well. The vital capacity is the most amount of gas that you can completely exhale from a complete inhale. So take a deep breath right now, as deep as you can, and then as all the way out, exhale as all the way as far as you can go, and as far as you can go until you can't blow out any further. That is a vital capacity. So that's exactly what it's stating here in the third point. You start up here at total lung capacity, so you take your deep breath in as deep as you possibly can till you're at total lung capacity, and then you slowly sustained exhalation for as long as you can go until nothing else is coming out. So the difference between a forced vital capacity and a slow vital capacity is this part, the slow part. One's fast, the other one is slow. All right. Why not do a forced vital capacity? Well, we just talked about this. If I just did a forced vital capacity only, then I'm going to have premature closure of my airways for someone that has emphysema, for let's say. And there's a bunch of gas that will stay trapped in their lungs. So over here, emphysema, here's your alveoli, emphysema. These are your floppy airways here. So if I have this patient exhale forcefully, I'm going to have this area flop closed really early on and trap a lot of that volume that won't make its way up and out of the lungs. However, same patient, floppy airways, I have them slowly exhale. I have them a lot more laminar flow coming back out, and therefore I will avoid some of that premature closure, and I will be able to exhale more volume and have a better measurement of the patient's volume. So slow vital capacity isn't looking at flow rates, it's looking at volume, right? So this is looking at, hey, do they have adequate volume? So it's teasing out if the patient has a restrictive process or not. So this is a test primarily looking at restriction, okay? So that's why not doing a forced. A forced vital capacity is where the patient exhales as fast and as hard as they possibly can, like they're blowing out candles, right? Really fast, really hard. That's to look at flow rates for obstructive disorders. This one's to look at volumes, okay? So slow vital capacity is a great way to look at volumes, especially for someone that has an obstructive disorder. Do you get a flow rate from this test? Remember, a flow rate by definition is volume over time. So how much over time? So no, this is not a test you get flow rates from. This is a test you're getting volumes from. What type of patients would benefit most from this test? Well, we just talked about it, the COPDers. Anybody that has a chronic obstructive pulmonary disease, they would benefit most because then they would be for sure teased out if they have a restrictive disorder with their obstructive or not. Because if we did the forced, that'll give us flow rates and a volume, but that volume might be lower than if we did a slow vital capacity and we have a lot more laminar flow, thanks physics, and avoid some of that premature closure of the airways. So usually your obstructive patients would benefit most from this. All right, so the technique here for a slow vital capacity, so this is you coaching this. You're going to start with that normal tidal volume breathing. And once you have about 3 or 4 breaths that are roughly within the same area of each other, you're going to have the patient take a maximum inhale as high as they can, and then slow, sustained exhalation till they can't exhale anymore, and then back to tidal volume breathing again. Hopefully that made sense. Usually you'll see a plateau down there, and especially you might see a little plateau at the top as well. But the big thing here is your exhaling is slow, but make sure they exhale as much as they possibly can. And usually you'll notice it on the graphic. Like I said, if you see that little end expiratory plateau down here, if you see that little plateau that happens, that's a big sign that they probably exhaled as completely as possible, and then they'll come back up again. The big key to making sure you have an accurate test here, and notice it's in bold here, is to make sure that you have a stable tidal volume, right, before they do the maximal inhale, maximum exhale. So if you have a large tidal volume, it might reduce or change some of the other volumes that we measure, or even the inspiratory capacity with the machine. So the idea here is you have to have a couple of tidal volume breaths from the patient doing the test that are within a couple hundred mLs of each other before you can take that deep breath in and exhale slowly and completely as possible. So make sure you have that stable tidal volume before you move forward with having them take the deep breath and exhale fully. That's a big key component here, and I would expect you to remember that key component. So once again, the technique, if you want to do this with me, breathe a couple of normal, quiet breaths. Just breathe. And after 3 breaths, take a deep breath in, and then all the way out. As slowly and completely as you possibly can until you're all the way out. And once you're all the way out, back in again. Right? And that's what you're looking at here. And like I said, most of the machines too will tell you if the patient has reached that stable tidal volume. So you're going to have some digital help nowadays. Thank goodness. And then hopefully we get to at least play with some of the machines at the lab. We'll see how that goes, but it'll be fun for us to actually see some of this. Like I said, please go look at some of the complete PFT videos if you can on the Peabody website. All right, so with a slow vital capacity, what's a good test? Well, you should have a plateau at the end of inhale and exhale parts, right? And I talked about this already, and I circled it on that little graph that I drew. You should have that plateau. In other words, no more volume is going in or no more volume is going out. They've gone as far as they can go. If there's a peak and then a change of direction, then that means that there is no maximum inhale or maximum exhale where there's no plateau. So ideally, in a perfect situation, you would see that plateau, right? And that's the whole plan, is to see that plateau. That tells you that you got the maximum effort out of that patient. Sometimes they're scared, sometimes they're confused, and that's okay. We just need to do that test again, right? When we're looking at these, we need at least 2 acceptable vital capacity tests, SVCs, within 200 mLs, or 5% of each other. So the vital capacity should be within 200 mLs of the forced vital capacity. Why is that there? And why would I care about comparing this to a forced vital capacity? Well, remember, the forced vital capacity is very much a similar test, only the patient exhales forcefully, right? It's a fast test, right? To look at flow rates and volumes at the same time. But with that one, the patient, if they get a higher vital capacity on a forced test than on the slow version of the test, then that shows that their effort on the slow version was poor. So we'd have to go back and do the slow vital again. If we see a bigger volume on the slow vital capacity than the forced vital capacity, that could actually be a sign more of air trapping with the forced vital capacity. So you never want to see a forced vital capacity have a higher volume than a slow vital capacity. If you do see that, that indicates that you need to go retest the slow vital capacity. Hopefully that makes sense to you, right? What could it mean if it's not within 200 mLs? That's what we just talked about. What if your slow vital capacity is greater than your forced vital capacity? Traditionally, especially if the patient has obstructive disease, this indicates air trapping, right? So I'm just going to write auto PEEP. If the FVC, the forced vital capacity, is greater than the SVC, then the patient effort on the SVC was very poor, so that's a retest of the SVC traditionally. All right, so hopefully you got that all down. I want you guys, if you can, and what some students have done that have been really successful, is make a chart where they, or get a 3x5 card, put everything about slow vital capacity on it, and then get another 3x5 card and put everything about forced vital capacity, or make a chart like what we've done in the past, where you list, all the indications, what this means, so on and so forth. But make sure that you're separating these out, because a lot of these can run together in your brain, and especially if you haven't performed these procedures or seen these procedures before in an extensive way, they can run together. So I'm going to encourage you to make a chart of some sort, or a 3x5 card, separate things, and then chart out what a slow vital capacity is, how to do it, what are the indications, what does it mean, is it looking at volumes or flow rates, and then forced vital capacity, and then MVV, and then so on and so forth, right? Big key there. I want you guys to be as successful as possible with this, and that I think is a big key to avoiding confusion when we're talking about all these different types of tests. Okay, the forced vital capacity. So this is the most common performed pulmonary function test. The most common performed pulmonary function test. This is the gold standard at the bedside of a patient. The doctor wants to see how severe their current lung process is for diagnostic and therapeutic purposes. So they order a bedside forced vital capacity. So you'll go into the patient's room and you'll do this procedure. And this one, the reason why it's one of the most common performed pulmonary function tests is you get both volume and capacity values. The only time that we're concerned that the volume value is not going to be accurate is if the patient has an obstructive disease. That's when you would inquire if they also want a slow vital capacity. Make sense? But you do get a volume and capacity with this. It's not easy, and you can get really tired out. The patient can get really tired out from doing this procedure because you're having them take a super deep breath in and then forcefully, as hard and as fast as they possibly can, blow out. It's a really big effort. You're screaming at them. Everybody in the next room is like, what are they screaming at that patient for in there? And you're really trying to get the most max effort out of someone. I mean, get your personal trainer voice or whatever voice you're going to get out, and just you're screaming, getting the best effort you possibly can, because this is a forced. You're trying to get that flow rate as well as a volume out of that patient's. So it can tire them out. That's why we were not going to do it more than, I think, 6 times. If you can't get reproducible results in at least 6 tries, then it can tire them out. Then we'll have to try again later. So just understand that all measurements are measured in BTPS. Why is that? Do you guys remember what BTPS stands for? I think someone said it. I'm just joking because it's a video. Body temperature, pressure, saturated, right? Because we're measuring the volumes and flow rates at body temperature, right? And then it's going to be pressure saturated because we have 47, we have body humidity as well, right? The humidity inside the lungs. That, remember that pH2O, that also takes up alveolar space, that's also in your lungs. So it's always going to be body temperature, pressure saturated, not ambient temperature, pressure saturated, but body temperature, pressure saturated. What happens if someone is an air trapper? What could happen to the volume part of this measurement? Will it go up, go down, or stay the same? If someone's air trapping and they're forcefully exhaling, right? Think about this emphysema patient again, alveoli and transition zone. If they're exhaling really, really fast, it creates chaotic turbulent flow and causes premature closure. So that means I've trapped a lot of gas back behind here, which would then cause hyperexpansion of the alveoli, right? Which would then burst capillaries, which would then make their surface area smaller and all that bad stuff. So if this happens in an air trapper, their volume measurement would go down, right? They would have less volume exhaled because more volume is stuck. It stayed in the respiratory zone. It's stuck in the lungs and they can't get it out. So their exhaled volumes would be lower. That's when you would probably look at doing a slow vital capacity as well to get an accurate volume for this patient. Could it be accurate in flow rates for air trappers? So instead of looking at volume, let's look at flows. Could it be accurate in evaluating their expiratory flow rate? Well, absolutely. It will be accurate in looking at their expiratory flow rate. So that will be just fine. In fact, this test is forced, and to look at a flow rate, the test needs to be forced. Right, so when you're looking at this, yes, it will be accurate for those obstructive patients. Big thing, and I just talked about it, is make sure you know the spirometer that you're using. You need to be a good coach and a good user of your equipment. If the patient gives you great effort, but you did not click start test, or you did not click something on the screen, or tap something on the screen, I should say nowadays, then you're going to lose that test altogether, and that could have been something that showed their max effort. That could have been a very valuable diagnostic and therapeutic tool for that patient. So make sure you know the spirometer, make sure you played with it or are familiar with it anyway. Big thing here is have the patient sit up straight, really tall, or stand. Traditionally on adults, we have them sit up really tall. We don't like to have them stand because if you exhale completely, you can actually simulate a vagal response, especially with a full inhale and a full exhale. They could vagal and pass out. Not a good idea. So we try to have them sit up as tall as they can. Standing works as well. We just don't want someone to pass out and hurt themselves. So sitting is the most preferred method, and just make sure their back is as straight as possible, and they're sitting up as tall and as proper as you could possibly think of it. You might need to use nose clips, and I showed that in the other video, right? Those little nose clips that go over the nose. That's a big thing because it can allow for gas to escape through the nose. So they recommend using nose clips for almost every pulmonary function test we do. You may have to demonstrate the procedure in front of the patient, and that's what I would always do. I always had my own spirometer, mouthpiece for the spirometer in my locker at work, and so I would take it out if I knew I was going to go do that test and be like, okay, you're going to take a deep breath in through this mouthpiece, as deep as you can, and then you're going to blow out really hard. And I'm not using the machine, but I'm just showing them with the mouthpiece how they're going to put it in their mouth. Some of the mouthpieces, they have to bite on it. Some of them, they put it inside their mouth and seal their lips. So there's going to be some different types of mouthpiece out there, but I just make sure that you might have to demonstrate it, and that might actually help the patient understand the procedure a little bit better. So demonstrate them, show them that you're taking a deep breath in. You're going to blast it out as hard and as fast as you can. Once you're all the way out, take that deep breath in, and you're yelling at this patient, right? You're giving them a good, strong encouragement plan. You are the biggest coach / cheerleader in the world to get as best of a effort as you can from this patient. So no EORs, right? No EORs in the room, right? Hopefully you know who EOR is, but you are going to be pep and cheer itself. You are going to yell and scream, get as much out of that patient effort as you possibly can. Take a deep breath in, blow it really hard, blast out, keep going, clap, make noise, whatever it is, get it going. If you can scare it out of them, do it. I don't know, I'm just joking on that one. Don't scare it out of them, but you're going to be a giant encourager on this. You got to be cheer and a good coach if you're going to get that max effort. Some of the best people that do PFTs have that part that just comes out, that really brings out that inner coach and cheer part of them. So get ready, have fun with it. Why not? It's actually a fun part of the day. What does the FVC measure? So it measures volumes, right? We talked about it has a vital capacity, and then the force part measures the flow rates, and then the vital capacity part measures capacity. So it measures volumes. So we have both the measurement of flow rates as well as the measurement of capacities and volumes. So it's in milliliters or liters, depending if you're doing a pediatric or an adult patient. So vital capacity is what we get. We also get the inspiratory reserve volume, expiratory reserve volume, forced expiratory volume, FEV, and then the T stands for time. FEVT is time. So remember, with forced vital capacity, low volumes, if we look at low volumes, it would indicate to us that this patient has a restrictive disorder like pneumonia or neuromuscular or something like that. Or if they have low flow rates, then it would indicate that they have an obstructive disorder. If both of them are low, then they could have a combined condition. What I can do to prove that it's a combined condition is then have them do a slow vital capacity to make sure that it wasn't just premature closure of those airways that caused their volumes to be low. So if I do a SVC and it also is within 200 mLs of their forced vital capacity volume, then I know that they have a combined condition. So it gives us a lot of information: vital capacity, inspiratory reserve volume, expiratory reserve volume, forced expiratory volume, time. Those are all valuable measurements that we can look at to see what type of disease process this patient might have going on and quantify it. How severe is their obstruction? How severe is their restriction? How severe is the combined condition? So this is why it's the most common test you'll see. So the FEV1 comes from this test. All right, the FEV1 is not a separate test. The FEV1 is read out or a product of the forced vital capacity. I'll repeat that again. The FEV1 is a readout or a derivative that we get from the forced vital capacity. So just like in ABGs, we get a CO2 level and a bicarb level from an arterial blood gas, right? So when we draw the arterial blood gas, we get levels from that. Well, just like that here, when we do a forced vital capacity, one of the levels we get from that is the FEV1. Okay, hopefully you got that. So this is how much volume they can exhale in the first second. When they forcefully blow out in that first second, this looks at a flow rate. So this looks at how fast or how much volume they can get out in that first second, because it's volume over time. So if the FEV1 is low, this means what? Right, this means it's probably an supposed to say obstructive disease. So FEV1 and the FVC are the most common standardized tests for obstructive diseases. So that's why we're looking, traditionally when we do a pulmonary function test, for most situations, we're looking for obstructive disease and how bad that obstructive disease is. And so when we do this, we're going to get an FEV1 and compare it to the forced vital capacity. So we're looking at how much they can exhale in the first second over how much they can exhale overall. And that's going to tell us, out of how much they have in their lungs, their forced vital capacity, out of how much they have in their lungs, how much can they get out in that first second. Okay, and what we're going to do ultimately is divide these two, FEV1 over FVC. When we divide those two, it becomes the FEV1%, right? Because now we're going to change it into how much percentage of gas are you going to exhale in that first 1 second. The bigger the number, the better flow rates you have, the less obstruction you have. The lower the percentage or the lower the number, the harder it is to exhale, the more obstructive they are. So let's get into that. So when we're looking at the FEV1, it looks at the FEV1%. And remember, the FEV1% is looking at the calculation FeV1 over FVC. You need to remember this. So that way when we do this, we can actually see how much they exhaled in that first second. What percent of their FVC were they able to get rid of in 1 second? I'll repeat that again. What percent of the FVC they were able to get out in that first second? Okay? The bigger the percent, the healthier the flow rate. The smaller the percent, the less healthy the flow rate. So when you see that percent sign, that means they compared it to the FVC, right? We divided it out, and then we took it times 100, which is just moving the decimal over, right? And we turned it into a percent. Other things that it does measure is what's called peak expiratory flow, or PEF, right? Peak expiratory flow, and the short version is PEF. So if you talk about PEFR, so PEFR, if you ever see PEFR on a report, that's peak expiratory flow rate, right? So if someone says their PEFR was, 18%, that's a terrible PEFR, but that's their peak expiratory flow rate. And it's not in a percent, so something's going on there. So forced expiratory flow rates, there's two of them that we can get. We have one that's called the 200 to 1200. And then there's one that's called the forced expiratory flow rate 25 to 75%. So the short version of these, and yes, I know, you love this because there's alternate ways that it can be put on there. The 200 to 1200 is also known as the FEF 200 to 1200, or the 25 to 75% is the FEF 25 to 75%. Well, what's the difference here? Well, the 200 to 1200 is usually looking at large airways. Large airways. It should be 200 to 1200, not 200 to 12,000. When we're looking at, so please cross that out. An error there. So when we're crossing that out, so when we're looking at the 200 to 1200, we're looking at after the patient starts exhaling, we're going to throw away the first 200 mLs that someone's exhaling. So let's say I'm exhaling and I'm at volume of 0. So I'm exhaling, and then this is where I'm starting. I'm starting at 0, and I'm generally exhaling. I'm blowing out. And so this little marker is moving up as I'm blowing out. So we're going to take the first 200 mLs that they exhaled, and we're not going to measure it. But we're going to measure how much they exhaled between 200 mLs and 1200 mLs. So we're measuring roughly what's in this space. So that we're going to look at the flow, or how fast they would exhale in that liter of gas, right? 200 to 1200, that's a liter of gas. How fast did that liter of gas move in the large airways? Because as you start to exhale, remember that's going to be your conducting airways that exhale first, then you'll get to your respiratory zone. So the 200 to 1200 is looking at more of your conducting airways, your larger airways. So this is something we can look at if someone has a tracheal tumor or an issue with their main stem, bronchi, so on and so forth. We're looking at their large airways, so we're measuring that liter of gas after the first 200 mLs. And we want to see how fast that liter of gas flows. If that flow rate's very low, that tells us that their obstruction tends to be more in their larger airways. Now, what about the 25 to 75%? And there's better graphs here. The 25 to 75% is someone is exhaling. And I'm just going to draw a down arrow. Someone is exhaling. So they're exhaling. That arrow is going down. I'm going to take 25% of this arrow and the 75% mark. So 25% and 75%. And I'm just going to use those marks. And this is as I'm exhaling. All right, so I already looked at my first liter of gas after the 200 mLs, which is sort of what's in your oral pharynx and stuff. And then I also want to see what's going on as they exhale further, right? This is further down the road. After they've already exhaled 25% of their volume, I want to see what this middle 50%, right? I want to see what this middle middle area, how fast the gas was able to flow after they already exhaled 25% of their volume up to 75% of their volume. So this middle area, I want to see how fast that gas was able to be exhaled. Well, this is because it's later on in the expiratory maneuver. It's not early on like the 200 to 1200. It's later on, right? After the first 25% has been exhaled. So it's going to tell us about sort of that medium to smaller airways. So which one would be more significant with asthma, 200 to 1200, or something in that medium to small airways like the 25 to 75%, or emphysema? There would be the 25 to 75%. Emphysema, asthma, that would be that 25 to 75. Flow rate would be very, very low because of those medium to small airways lose their structure. Remember, there's less cartilage the further down you go, and there's going to be more likely to lose their structure and or have that bronchospasm have more effect because there's less cartilage, right? There's less structure down there. So someone that has asthma, emphysema, that 25 to 75% would be really low. Someone that has like a tracheal tumor, an upper airway issue, a large airway issue, would have a low flow rate on the 200 to 1200. So they tell us different parts of the airways. I know they have a smaller airway flow rate issue, then I can look into things that would cause a small airway flow rate issue like emphysema, asthma. If they have a large airway, then I would look at other things like a tracheal tumor, vocal cord dysfunction, things like that. Okay, the FEV 1%, we've already talked about this. FEV1 is compared to the FVC. So all we're doing is just dividing it. That's all, okay? We're just using it as a divider. So we have the FEV1 over the FVC. That's it. We're just dividing the two, and then we'll times 100 to turn it into a percent, of course. So this is looking at how much of the FVC is exhaled in that first second, and this is a flow rate, important. So volume over time. If the FEV 1% is low, then the patient has what? If it's looking at a flow rate, what type of disorder has low flow rates? You should have said an obstructive disorder. So right here, FEV1 over FVC. So this is a big situation because this is what is vital to distinguishing if this patient has an obstructive disorder. Now here's the thing, you need to know this, and there's a reason why this is bold. It's measuring flow rates, and a normal FEV 1% is 75 to 85%. So remember, in the last lecture, we were talking about what are normals, right? How do I know what normals are for most of my PFTs? And normals for most of them was 80 to 120% of predicted. Now, this is going to be of predicted as well, but in the first second that you exhale, it's going to be a little bit different. So this is the only outlier, right? This is the only outlier there. The normal is 75 to 85%. So within that first second, so here, let's make a graph, okay? If I'm exhaling and I reach the plateau because I've exhaled as far as I can, so let's just say this vertical axis is volume, this x-axis is time. So I should have 75 to 85% of my breath exhaled in that first second, right? Should I have 100% of it exhaled in that first second? No. If I can exhale 100% of my lungs in that first second, something's going on. It's not normal, right? So 75 to 85% of my breath should be exhaled in that first second. Not 100% or not 5%, but 75 to 85% of that breath should be exhaled in that first second, okay? Of all my volume. So 3/4 of my breath, roughly, should be exhaled, and I should have a little bit left over after that. That shows a normal rate. So if someone's FEV 1%, if I told you on an exam, or if you were looking at a pulmonary function test, and I said someone's FEV 1% is 48%, you would say that's low, and that's a flow rate, so that's an obstruction, right? If I told you the FEV1 was 90%, you would say that's high, and that's not normal, that's outside of range. But the big thing here that we're looking at with obstructive disease is it lower than 75%? Okay, the 200 to 1200 and the 25 to 75%, we already talked about this, and this is just supporting what we already talked about. So this is the average flow rate during the first part of the forced vital capacity. So we're looking at the 200 ml mark to 1200 ml mark, and how fast was the gas between the 200 ml mark and the 1200 ml mark, right? For that liter of gas, how fast did it go, right? And that tells us about those large airways, okay? That 25 to 75%, that flow rate, it's after you've exhaled 25% of your breath to when you've exhaled 3/4 of your breath. And that's looking at how fast your gas is moving during that middle 50% of the test. So which one's going to be more specific to small airways? Well, that's going to be the 25 to 75% because it's later on in the expiratory maneuver. As you exhale, you got to empty your dead space. You got to empty your mouth, your oral pharynx, your laryngopharynx, your trachea, your main stem, your segmental, your subsegmental bronchi. Like all those guys will empty first, and that's what we're seeing in the 200 to 1200. How fast the gas in your conducting airways is coming out. Then as we continue to exhale, we're going to eventually get to the areas that are transition and respiratory zone, and that's going to be your 25 to 75%. That's how fast the gas is moving in your medium to smaller airways. So which test is more specific to small airways and would detect asthma, emphysema issues? 25 to 75%. The way that I remembered this when I was in school, I don't know if this helps any of you, is if it's a small number, 25 to 75, it was small airways. If it was a large number, 200 to 1200, it was the large airways. That's how I remembered it. I don't know if that helps any of you. Hopefully, some way I've explained it here might hit home. All right, and this is just the visual graph, and this is exactly what's in your book. The 25 to 75% here is after they've exhaled, and that's what we're looking at here. Volume is your y-axis, and time is your x-axis. And as they exhale, right, as they go from 0, we're going to exclude that first 25% because that's going to still be your medium to your larger airways. And then we're going to look at medium to smaller airways in this area here. So that middle 50% of what they're exhaling is going to represent how fast the gas is moving in their medium to small airways, which looks at their things that would be small airway diseases or conditions like emphysema, asthma. That's what you're seeing here. The 200 to 1200, that's what you're seeing here. Same thing, volume on our y-axis, time on our x-axis. As the patient exhales, that first 200 mLs we throw out, we don't measure it, but once they hit that 200 ml mark to that 1200 ml mark, we're going to measure how much volume or how fast the flow rate is while they exhale this 1 liter of gas. And that's going to tell us sort of about their larger airways. So as you can see down here would be their 200 to 1200, which would be large airways, and up here would be your 25 to 75, which would be your medium to small, right, airways. So you can sort of see on a pulmonary function test, your large airways will come first as you exhale, and then you would get into your medium to small airways. All right, the FEF 25%, 50%, and 75%. This part can be confusing, and I won't test it extensively with you guys at all, but I just want you to be aware of what it is. This is going to be looking at volumes at different parts of the FVC test. So instead of looking at the 25 to 75%, we're just going to say, hey, what was their volume at 75%? Or what was their volume at 50%? Or what was their volume at 25%? Okay? So it looks at the different parts. How much volume had been exhaled? So the FEF 75% would mean that the FEF, that the amount that they've exhaled, right, how much volume would mean that 75% 75% has been exhaled. When we're looking at the Vmax, it does it backwards. It's like a mirror image. Great. It's just like Facebook Live, right? It does it backwards. It does a Vmax 75, 50, and 25. So this looks at volumes of the different parts of that VC test. So they share that in commonality, but it looks at the volumes remaining in the lungs. So how much is still in the lungs? So an FEF 25% would mean, right, how much volume is remaining in the lungs? That 25% is maintained in the lungs. So one's looking at how much has been exhaled. The other one is looking at how much is still in the lungs, so 25%. So how much is in the lungs versus how much has been exhaled. So they're looking at different things. One is like how much is left over, and the other one is like how much came out. So they're looking, even though they look very similar, they're looking at different things. One is how much has been out, has come out into the machine. The other one is how much is left in their lungs, right? So this is a different graphs, and these are the graphs that you're going to see when you're looking through a pulmonary function test. This first one on the left is your typical volume time scaler, and so when we're looking at this, we're going to see our FEV 0.5. Don't worry about that yet, but we see where FEV1 is, and hopefully that's somewhere around 75 to 85%. And then our FEV3, we should be starting to hit our plateau, hopefully by 3 seconds. All right, so as the patient exhales, all right, that's what you're seeing here with the graph, right? They're exhaling, it's moving up in volume until they sort of reach as much volume as they can out. Over here on the right, you're going to see sort of this flow volume loop, right? Be very familiar with this. Even mechanical ventilators have flow volume loops on them, so you might have to look at them on those. So this measures volume on your x-axis, as you can see. And then your flow rate is going to be on your y-axis. So instead of volume being on your y-axis, the flow rate's on your y-axis. So this one doesn't look at time, but it does look at flow rate. Okay, so as the patient exhales, so they're going to start from 0 here. They're going to exhale. And then as they're exhaling, they're going to, their flow rates are going to start dropping. And this is where we get our 25 to 75%. And this is where we have our middle 50% that they were measuring for small airways. And as we get almost all the way out, and then they're going to take a deep breath in, which is their peak inspiratory flow rate, and then back down to 0. So they're going to breathe out, blast out, which does the top part of this graph, and then as they breathe in, that's the bottom part of the graph. Therefore, inspiration and expiration. So as they exhale, it peaks up, and then as they inhale, it peaks down below that line. The distance or the width of this circle, of this flow volume loop, is going to be their forced vital capacity. So we could still see a volume on there, right? But we're looking at flow rates. And the cool thing about this, if someone has a very low flow rate on their 25 to 75%, let's use blue. Let's say if we see this big scoop right here. So we see it scoop down and then they breathe back in. But we see this giant scoop here where their flow rate really slowed down while they were exhaling. Well, that scoop is a classic sign of an obstructive disease of the small airways like we see with asthma and emphysema. So this is going to give us a good hint if they have an obstructive process going on. All right, so these are slides that are just, hey, let's look at how to look at an ABG, or not ABG. Let's approach this like we did our ABGs, where we put our labeling on them so we can tell if this is an obstructive, restrictive, or both pulmonary function test. So obstructive, restrictive, or combined results. So when we're looking at this, I want to label my volumes and my flow rates. Okay, so when I'm doing this, my vital capacity, and we'll just put the letter S here for slow vital capacity, right? And because I have a forced and then I have a vital capacity. So we'll just consider this a slow vital capacity. So slow vital capacity is what? A volume or a flow rate? So this is going to be a volume. So I'm just going to label these on the side. This is a volume. A forced vital capacity tells us both volume and then in flow rate. FEV, right, forced expiratory volume at 0.5%, FEV1, FEV 1%. These are all looking at flow rates. So I'm just going to put the letter F. Flow rates. So here in this situation, I have a patient where their predicted level of their slow vital capacity was at 4 liters. Okay, so that's what was predicted for their height, age, gender, right? That was what's predicted for them. And when we did the test, we measured 4 liters. Do you guys sort of see what's going on here? And then we did a forced vital capacity. What was predicted for their height, age, gender was 4 liters, and we measured 4 liters. So they were at 100% of predicted for both of those. The FEV, which is a flow rate of 0.5, this is the flow rate, was predicted at 2 liters. They got 2 liters, so they were 100% of predicted. Same thing going all the way down. So you see the predicted, what's predicted for them, what they got, and then what their percent of predicted is. And so that's what we're going to look at here, is that their FEV1 is 18% of predicted. We know that's a severe obstruction, right? Very, very severe. And so this is typically, you're going to see obviously a lot more things on a pulmonary function test result, but we're just going to start here. And what I recommend doing is just going through and labeling volumes and flow rates to begin with, and then you know that if a volume is low, it equals a restrictive disorder. If a flow rate is low, then it equals an obstructive disorder, okay? So this is a perfectly normal test, right? Everything was 100% predicted. Nothing to talk about here, just making you guys sort of able to initiate or see what this looks like. Okay, so let's do a different challenge here. So before I do this, I'm going to write my key. If I have a decreased volume, I will have a restrictive disorder. If I have a decreased flow rate, I will have an obstructive disorder. Okay, so let's tally this out. Volume and flow rate. So now I'm going to label. So understand this is just an issue where the top part just needs to be moved over a little bit. So just deal with my formatting, give me some grace here. All right, so we have a vital capacity and a slow vital capacity that's measured at 2 liters. It's predicted at 4 liters, and that's half of what's predicted. So this slow vital capacity is a volume. So I'm going to put, hey, I already have a low volume. Okay. Forced vital capacity, we get flow rates from it, but it is also a measurement of volume. So I'm going to put a little volume next to it. Also 50% of predicted, so that means our volume is low there as well. Okay, so far this is looking restrictive. Now we got to go into our flow rates. So flow rates, those are little F's for flow rates. Now I need to see if my flow rates are low. So is this a combined condition or just a restrictive condition? So I'm looking at my flow rates. I got 1 out of 2 liters, so that's a 50% of predicted. When I get the FEV 0.5. FEV 0.5% is 50%, and it was predicted at 50%. So I hit my flow rate there. My FEV1 is 1.5 liters, and I got 3 liters. So that is 50%. But the big thing here is looking at the FEV 1%. Remember, this is the one we key the flow rates on, right? So we're going to key in on the FEV 1%. Notice I didn't write any of those others over here on the side. I'm going to key in on the FEV 1%. Well, I'm going to ask you, how do you calculate an FEV1%? Because I might have to actually ask you to calculate an FEV1% on a, an exam. So when we're looking at the FEV1%, you take their volume, their vital capacity, and so remember, they only had 2 liters, right? So it's your FEV1 over your FBC. So the FBC was 2 liters, and their FEV1 was 1.5 liters. So 2 goes into 1.5. 0.75, which when we take it to a percent would be 75%, which remember, an FEV1% between a normal is between 75 and 85%. So their FEV1% is normal. So I do not have an issue with my flow rates. I have an issue with my volumes. So therefore, this is a restrictive disorder. So let's check. It's exactly what we're doing here. We see here that this is just the FEV 0.5 is just the volume at 0.5. The FEV1 is just the volume at 1. But when we compare it to the FBC, that's where we get the percentages. Right? When we compare it to the FBC, that's where we get the percentages. And when we did that, we're normal. So therefore, right, we have a restrictive disorder because our volumes are low and our flow rates were normal. All right, let's try another one, and you can pause this, work ahead, and then work it with me and see if you got it. So let's try this one. So obviously I'm going to put my key if my low volumes equals restrictive, low flows equal obstructive. And then I'm going to do my little tally over here, and you can do it differently. And, you guys can do what works best for you. There's a lot of different ways to do this. This is just my selected method. Okay, so my slow vital capacity, which is a volume, over here is normal, so great. My forced vital capacity, which is, in this case is a volume, 75%. Oh, so there's a difference between the slow vital capacity and the forced vital capacity here. Interesting. Okay, so that one's showing low. Interesting. Okay, my FEF, and these are flow rates. And we'll just look at the FEF1 and the FEF 0.5. We can also look at it as well. So when we're looking at this, the percent predicted for both of these is low, right? So we're looking at low flow rates for both of these. I got 50% of predicted for my FEV1%. That's obviously an obstructive issue, right? Because my flow rates are low. That's what we're looking at this guy here. What about my volume? I had a normal volume for my slow vital capacity, but my forced vital capacity is not normal. It's only at 75% of predicted. Remember, a normal for these is 80 to 120% of predicted. So this patient obviously is at 75% of predicted. So the forced vital is at 75%, but the slow vital is at 100%. Why? Because I got a normal volume when I did it slowly, but when we did it fast with a patient that already had an obstruction present, their volumes got lower. So this is a classic sign of, hopefully some of you said it, an air trapper, right? Premature closure of the airways stopped gas from coming out, and that's why that forced vital capacity was smaller than the slow vital capacity. So this patient, if we did not attain a slow vital capacity, we would say that they had a combined condition, right? Because the forced is low and the flows are low, so that would mean that this patient has a combined restrictive and obstructive disorder. However, because we were very intelligent and we did in slow vital capacity, we now know that this patient has an obstructive condition only. There we go. So hopefully you're starting to get sort of the feel of this. We're looking at volumes and flow rates, and that was a good example of why a slow vital capacity could come in very handy when we're doing this. Let's do another one. Uh-oh, this looks a little bit different. So I have a forced vital capacity, and it's 3 liters, which is 90% of predicted. So this is where you can still do if I have decreased volumes equals restrictive, decreased flows equals obstructive, and then we can do our little tally thing, volume flow. All right, so far my forced vital capacity is 90% of predicted, so that's good, right? I'm saying, hey, there's no slow vital capacity, so that's good. I'm just going to put N for normal. Okay, my FEV1 is at 2.55 liters. My FEF 25 to 75% is 88% of predicted. And my VSET is about 3 seconds. That's how long it took. So how do I know what their FEV1% is? You're like, Derek, I know how to calculate an FEV1%. All I'm doing is taking the FEV1, which was 2.55 liters. Remember, it's FEV1 over FVC, which was 3 liters, and we're going to divide that out. 3 goes into 2.55. 0.85. So we have, when we turn it into it would be 85%. So our FEV1 would actually be 85% here. So this means that our FEV1%, which is the big key flow rate we're looking at, is 85%. What's a normal? 75 to 85%. So our flow rate's normal. So my volume's normal. My flow rate's normal. So in this case, everything here is normal. So hopefully you can see I might ask you something where you might actually have to remember that there's a calculation and what goes into it and why that calculation is so key. That's the big one that we focus on, is the FEV1%. Okay, let's do another example problem. Love them. FVC is 2.8 liters, and this is 50% of predicted. Oh heavens. All right, so let's do this. If I have decreased volumes equals restrictive, decreased flows equals obstructive, and then we'll do our little tally thing, and then volume, flow rate. So forced vital capacity is 50% of 2 liters. Now, on this patient, did we get a slow vital capacity? No. Oh, heavens. Well, let's hope that doesn't factor in later on. So far my volume's low. My FEV 0.5 is 2.29 liters. FEV1 is 2.5 liters. And my VSET is 3.5 seconds. Okay, so I need to figure out my flow rates. Well, it doesn't give me a flow rate. It tells me what their FEV1 is, but I don't know what their flow rate is. So guess what? Their flow rate for the FEV1%, now you have to calculate it. So remember, it's FEV1 over FVC, which equals, FEV1 is 2.5 over 2.8. 2.8 goes into 2.5. 0.89, so that would be 89% when we just multiply it by 100. So our flow rate is actually normal. And in fact, in some cases, right, normal FEV1% is 75 to 85%. So this is actually an increased flow rate over here. So we have a severe restriction, right? We have a 50% restrictive effect because remember, volumes low volumes equals a restrictive effect. It's so low that the volume of their container, just think of like a shot glass, the volume of their lungs, the amount of gas the lungs can contain is actually so stiff, like there's something causing such a severe restriction that their lungs are going to empty very fast because the container is so small to begin with. And so that can actually cause an increase in our FEV1% here. So in this case, this is a restrictive effect, and this would be a pretty significant restrictive effect. All right, hopefully you're getting the hang of these. Like I said, you could always pause when we go to these and then work through them as well. All right, let's do another one. I'm going to do it the same way I did the other ones. Decreased volume equals restrictive. Decreased flow equals obstructive. Volume, flow rate. Okay, my forced vital capacity is great, 80% of predicted. Remember, normal is 80 to 120 there. So far, I got a normal there. FEV1 is 2 liters. Well, that's just a volume. I need to figure out 25 to 75. My 25 to 75 is 60% of predicted. I don't know about that. And it took this person 15 seconds to exhale. Hopefully you remember time constants, what happens with raw, a long time constant. 15 seconds is a long expiratory time constant, so you might be able to figure out what's going on here. But I need to figure out this person's flow rate. And I know their 25 to 75% is really low, which tells me medium to small airways, not healthy, right? But what's their FEV1%? So the FVC is 4 liters, and their FEV1 is 2 liters. So this is pretty straightforward. 0.5 equals 50%. So their flow rate, their FEV1% is 50%. So their flow is very diminished, and our volumes are normal. Therefore, this patient has a obstructive disorder going on. Yay, this is looking good. Hopefully you're catching on. Let's do another one. All right, like I said, always pause it if you need to, or speed it up. Decreased volumes equals restrictive. Decreased flows equal obstructive. Little tally box. All right, my forced vital capacity is only 39% of predicted. That's not good. Well, they didn't do a slow vital capacity. Interesting. All right, so FEV1 was 900 mLs. And it doesn't give me, oh, their FEF 25 to 75% is also 60% predicted on this patient. So it tells me there's something going on with their small airways, but is there a significant, and it took them 10 seconds to exhale, is there a significant decrease in their FEV1%? So when I'm looking at the FEV1, FVC is 1.5 liters, I'm just going to say right now that they have a decreased volume, because they didn't attain a SVC to really see here, but let's see if they have a flow rate issue. So I'm going to take their FEV1, which is 900 mLs, or 0.9, right, because we're looking at this in, and then this is 1.5, right? So 1.5 into 0.9 equals 0.6, which would equal 60%. So their flow is also low as well. So this looks like it could be a combined issue. This is the big case here on this patient. Let's say we did get a slow vital capacity, and the slow vital capacity was 80% of predicted. Then that would show this patient has that air trapping thing going on, that premature closure of the airways. They didn't get it on this patient, so therefore it looks like, without any further information, this patient has a combined condition. Let's see. Yep, this would be a combined condition. Without further information, we have to go with what we have. So in theory, they would be treating this patient as if they had both, because we just did not attain that second slow vital capacity test. All right, so hopefully that was some good practice for you. Let's get into just some little things here and there. When you do these tests, one of the limits for acceptability here is you need it to be at least, there should be a T there, at least 6 seconds in length. So when they exhale, should take them at least 6 seconds. If they have a severe obstruction, it can take up to 15 seconds. And that's what we've seen in one of those examples. In some severe restriction cases, it may only last like 4 seconds because their lungs can only contain so much volume. If they're severely restricted, they'll probably have 100% of it out pretty quickly there. The other thing here, there shouldn't be any coughing or hesitations, right? If there's coughing or hesitation, we can't accept that test. We have to do another procedure. We have to do that, repeat that test and throw out the test that had the coughing or hesitation in it. And then there should be a distinguishable plateau. Remember where I was talking about like the slow vital capacity? You need 3 to 4 tidal volume breaths that are equal, and then deep breath in, and there should be a plateau at the top and at the bottom, right? There should be a plateau down here and a plateau up here. And that shows that they hit as high of an inhale and as high of an exhale as they possibly could go, that they gave you as much as they had. If you see it where it just gets pointy, and then down here, it just stops abruptly and then goes back up with no plateau, like a V, like an up arrow and a down arrow, instead of a plateau and a plateau, then you know that that was probably a premature stop and they had more in their gas tank, so to speak, right? So there should be a distinguishable plateau. You need to have at least 3 reproducible tests. You don't want to do the test more than 8 attempts. This is going to make the patient tire out pretty straightforward. And you may get it before 8 attempts. Now you're talking about someone that already has sick lungs and you're making them do this whole procedure. It's going to be very fatiguing for them. And so they can fatigue before 8 attempts, but according to the American Thoracic Society, ATS, no more than 8 attempts, they'll fatigue pretty quickly. When we're doing the test, we're going to use the largest forced vital capacity and the largest FEV1. And that's because it's effort, right? The largest vital capacity that we get, the largest FEV1% or FEV1 number we get, we're going to use that and use that as our FEV1%. So if on test 1, right, let's say we do 3 tests, test 1, test 2, test 3. And then we have an FVC of 3 liters, 2.8, and 3.1. So we'll do FVC. If we have an FVC here, out of these 3 tests, we're going to take the largest FVC, which would be the 3.1 liters, and then we're going to also look at the FEV1. So FEV1 out of test 1. Out of test 1, they did a 2.2. Test 2 they did a 2.0, and then they did a 2.1. 2.1 there. Then we're going to take the 2.2 as their best FEV1. So then we're going to use those 2 numbers as our best FEV1%. Does that make sense? So we're going to report the largest FVC and report the largest FEV1, and we're going to use those 2 numbers to then divide out and get their FEV1%. So in this case, we would take 2.2 over 3.1, which would be roughly 71%, something like that. It'd be low. 71% is what I'm just going with mentally here. So when we're doing this, that's what you would report because that's their best FVC and the best FEV1. Even though they came from different attempts, we're still going to take the best part of those. So all the flow value, so that's how we figure out their best FEV1%. Now we need to figure out how do I figure out out of these 3 tests that this patient took, test 1, test 2, test 3, how do I figure out which flow rates to use if I'm doing their best effort? So this is where we're going to do some more math. Aren't you excited about this? But here it's just adding. Yay! So we're looking at all the best tests. So in this case, I'm going to add up, right? It's the sum of the FEV1 and FVC for each test. And then the test number that has the highest flow rate, highest values for the FEV1, FVC, I'm going to use the flow rates from there. So let's say all the flow rates for test 1 are circles. Circle, 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 circle. And we'll just extend these. And let's say the flow rates down here are squares. Squares, squares, squares. And then test 3, we'll do here, let me erase this real quick. All right. Test 3, we'll do triangles, 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 triangles. Okay. So how do I know which flow rates to use, the circles, the squares, or the triangles? So what I'm going to do is I'm going to add up my FEV1 and FVC. So this first one was 3 and 2.2. And that is 5.2. Okay, now I'm going to go to the next one, which would be just adding 2.8 and 2.0, which would be 4.8. Okay, and then the third one is 3.1 plus, what was that, 2.1 is 5.2. Oh, great. I didn't think this out ahead of time. All right. So in this case, I have flow rates for both circles and triangles. I could pick either one of these flow rates because they're both equal to the same value. But theoretically, let's say this third one was 5.0. 5.0, then I would take all the flow rates that we have from test 1, and I would transfer those over at, as reporting their best test. So over here, I'd be like, yeah, all those flow rates are the best flow rates we're going to have. I did not think ahead on that one. But realistically, you probably will have a difference between at least those 3 tests when you add up the FEV1 and FVC. And then the largest sum of the FEV1 and FVC, you're just going to take all the flow rates from that category and then say those are the ones that we're going to go off of, right? So the sum of the highest FEV1 and FVC, which in this case was these ones. And so let's do an example problem besides the one that I did here. Okay, so best test. All right, between trial 1, trial 2, and trial 3, which one had the highest FVC? This would be this one. So 5.35 is what we would report. That's their best FVC. Okay. Then FEV1, which one is the highest FEV1? 4.41, 4.35, 4.36? Well, you say, of course, 4.41. Even though those came from different trials, that's still their best numerical value they got. All right, so now how do I figure out their FEV1%? Well, it told me their FEV1% from trial 1, trial 2, trial 3, but that's from those independent trials. I need to figure it out from these two. So now I need to do 4.41 over 5.35, right? So I need to actually do it with my best test values because we're reporting best test values, so we need to do a best test FEV1%. So I need to divide 4.41 over 5.35, and that should be 82%. So that's what I'm reporting because I did these two to get this one, right? You're not going to just transfer one of these, right? That's one of the biggest mistakes I see is people just transfer one of those over and be like, yeah, that number is the highest. No, this one you actually have to use the best test results you got and then divide it and put it in there. Now I need to know, okay, which trial flow rates do I use? Remember, do I use trial 1's flow rates, trials 2 flow rates, or trials 3 flow rates? Well, trial 1, trial 2, trial 3, they do vary from each other. How do I know which one is going to be the best? Well, now I need to add the FVC and the FEV1 in order to see which one is the highest number, and I'll use the flow rates from that. So let's do that. So trial number 1, we had a FVC of 5.2, and we're going to add 4.41, and we're going to get 9.61. Okay. Trial number 2, we got a FVC of 5.3. Then we're going to add 4.35, and we get 9.65. Okay, that's bigger. So, and then we'll do the third one, 5.35 for our FVC, and then we're going to add the FEV1, which is 4.36, and that's 9.71. So numerically, trial 3 has the highest FEV1 plus FVC. Therefore, we're just going to transfer all of these over here. So when we're reporting the best test, we're going to say that their FEF 25 to 75 was 3.94. Their 50% was 3.41. Their 25% was 1.89, and their peak expiratory flow was 9.89 liters. Do you guys sort of see this? You got to add up the FVC, FEV1, and the trial that has the highest numbers. You're going to use all those flow rates and transfer them over. So I would expect you to be able to do this on an assessment document in the near future. So what makes them important? We're looking at obstruction and restriction when we're looking at slow vital and forced vital capacity, and it can also tease out if it's a truly combined condition or not. So we're looking at that relationship and trying to figure out, do we have a combined condition or just a condition on its own? And that's going to make a difference on how we treat the patient, what type of medicines we picked, what type of therapies we picked, so on and so forth. When we're looking at something where we know it's just obstructive disorders, we can do something as simple as a peak flow device to measure their peak flows on a daily basis. So this is something that we can get during a forced vital capacity on the machine. It'll give us a peak flow, or we can use a peak flow meter, right? These little guys over here, and that they forcefully just blast out, force that breath into there, and it measures how fast their breath was ultimately. And this is big thing, effort dependent on these patients. So if you can get them to get you your best, get the best effort out of them, you'll be doing well. And that's why we record the highest number, right? We're going to have them do at least 3 attempts. The 2 largest should be within 5% of each other. Just to make sure you got the best effort. If they get like a 100 and then a 900 and then a 200, they're sort of all over the board. But you should make sure there's at least 2 that are pretty close to each other there, that 5%. And then we're just going to record the largest of the 2. You don't average them. You just record the highest value only. All right. So record their personal best. When they are healthy baseline, they need to measure themselves at healthy baseline. Where is their best, their personal best with their disease condition? Where's their personal best at baseline? Not where a normal healthy lungs are at baseline. Right, what's predicted for someone that has normal healthy lungs? No, we're not going by normal healthy lungs. We're going by what their best day looks like, and we're going to compare them to their own best day. So we usually have them do it in the morning and night, and we compare it to their personal best, right? Notice that's in bold there. That's important because I had a patient, and I may have told you guys this story. I had a patient that they were keeping her in the hospital with her asthma because she was in her yellow zone, just like you see how the red, yellow, green zone. She was in her like yellow to red zone every time they did it in the hospital, and they weren't going to release her because she wasn't doing well. And I went in there and I asked her, I'm like, well, where's your personal best? And they had been comparing her to what was predicted for normal healthy lungs. She's like, well, my normal is normally here. And I'm like, well, then you're in your green zone. You're doing well. And I discussed this with the physician. The physician then called the consulted pulmonology. And pulmonology is like, yeah, if you compare her to normal healthy lungs, she'll never get there. She'll stay in the hospital the rest of her life. So we always make it to their personal best because remember, their lungs aren't normal. It's okay. We just need to make sure that we have the bar that they can reach, and that's what we're doing here. So compared to their personal best, compared to what's predicted, because remember, predicted is based upon healthy lungs, not on lungs that have asthma or anything else going on with them. This is cool too because depending on where they're at on their zones, it can warn us if their asthma is getting better or getting worse. And it can give them a warning if they're in their yellow zone. Maybe they stay inside, or maybe they do an extra inhaler treatment, or they take preventative measures and watch themselves a little bit closely. If they're in their red zone, then they can work themselves out of it before they really see a lot of symptoms arise. So this is the stoplight thing. We do this for kids and adults. Some of you may have seen this before. If someone's in their red zone, they usually are coughing. One of the first signs of a bronchospasm is a cough, right? So coughing and wheezing, very classic signs of asthma. So trouble breathing. Sometimes they have that trouble talking, right? Remember we were talking about one or two word dyspnea, walking their lips, they might get some cyanosis going on. The big thing here for these people is to get immediate help if they can. Call the parents, because this is usually what we do for kids that have asthma. Notify the parents, give the medication for their asthma action plan, which is something that we would have the physician fill out before they're discharged, and or have their primary care physician fill out, right? In other words, do nebulizers, get them to a facility that can support their respiratory needs. If a patient's in their yellow zone, they're still going to have some symptoms like coughing and wheezing, shortness of breath. But this one is where we're just going to give them medications. We're going to still contact their family, but they need to stay away from anything that would trigger their asthma. So let's say it's just certain types of pollen or food or certain things out there that would trigger their asthma. They're going to try to stay away from that. And we're just going to monitor the child. It doesn't mean that they need to call 911. If someone's in their green zone, that means they're doing good. They're under control. We're just going to try to avoid triggers just as possible, like prevent it in the first place. Make sure we have the meds ready to go. The symptoms, they're not coughing or wheezing or anything like that. So how do I know someone's zone? So 80% of what's predicted for them, their baseline, not of what's predicted for someone with healthy lungs, but for their baseline, 80% to and above is going to be their green zone. 50% to 80% is going to be of their peak flow. We're talking their peak flow device, peak expiratory flow rate. They're 50% of their normal to 80% of their normal, or 79, I should say, percent of their normal is going to be their yellow zone. So if they blow when they get into their yellow zone, which is 50 to 79% of what their baseline is, this is when they're going to follow these action plans. If they're in the red zone, someone sees that they're starting to have that cyanosis, the peripheral cyanosis, then we're going to call someone right away and make sure we get them as much intervention as we possibly can. And that's anything less than 50% is the red zone. So we're going to set this for each patient on their little peak flow device, so we sort of know where they're at and what symptoms they would have in each of the zones. Pre and post bronchodilator studies, you'll do these. There can be a lot of difference pre and post, so you never know what you're going to see here. And this is going to look at how reversible the airway obstruction is. So we're going to look at the FEV 1%, and it needs to be low to begin with. If it's in the normal range, we're not going to see a difference. It needs to be low to begin with. So if we have a patient and they do an FEV 1% less than 70%, let's say it's 54, then they're perfect. We can go ahead with the test. If we do it and their FEV1 is 75%, that's a normal range, and we're not going to do it because their lungs are actually doing fine. We're not going to see a difference. So lungs have to sort of be in a 70% or less state. So what we're going to do is we're going to do a pulmonary function test. We're going to look at their FEV 1%. And we're going to make sure those results are reproducible, so we'll do at least 2 to 3 tests. Then we're going to give them a bronchodilator. We're going to give them an albuterol or a Xopenex. We're going to give them some sort of bronchodilator. We're going to wait 10 to 15 minutes, and then we're going for the drug to kick in, to take effect in their lungs. Then we're going to redo the pulmonary function test. We're going to redo the FVC. When we redo the FVC, if we see a 12% or more increase in the FEV1, that means they responded well. If we see an increase of over 200 mLs, that means they responded well. In other words, their lungs are opening up. They respond well to that bronchodilator. So to do the percent change, we're just going to subtract the difference between what they get pre-drugged and post-drugged over the pre-drug. Sort of like the O2-ER, if you guys remember calculating that. You're like, yeah, I loved the O2-ER. That was my favorite calculation. No. Anyway, so this is how the percent change is calculated. I would expect you guys to remember that, and especially that 12% change in the FEV 1% or an increase in 200 mLs would show that someone's reversible, right? Because that's what we're looking at here is reversibility. Reversibility is there for their reactive airways. So before we do a pulmonary function test, especially one that's involving a bronchodilator, like a pre and post test, we need to look at withholding certain medications that might throw off that procedure. So regular beta agonists, like your bronchodilators, anything like that, we're going to wait at least 8 hours before we perform that test. So this is why we usually do them in the morning for a lot of our pulmonary function tests, because most people have at least withheld overnight. Sustained or SABA, sustained action beta agonists, make sure it's been at least 12 hours, and then parasympathetics 8 hours. And inhaled steroids, they take like 4 weeks to build up in your system, and then it's going to be a while before their effect is sort of out of the system. So we just tell the patients to maintain use. That's not going to be something that we're able to get accurate numbers on if we just have them stop the day before or night before, so on and so forth. So they're going to continue taking their inhaled corticosteroids. But anything that's a parasympathetic or a beta agonist or just a short-acting beta agonist, we want to withhold before the test. All right, the DLCO, we talked about this one in pulmonary. This one's great for looking at how easy it is for gas to cross over the AC membrane. Very important for conditions like emphysema, interstitial lung disease, titrating chemotherapy. These are very, very important tests. And when we're looking at it, we're using carbon monoxide. Why carbon monoxide? Remember, 200 to 250 times the affinity for the hemoglobin molecule compared to oxygen. That's crazy. So it really loves to be diffused into the bloodstream because it is in love with that hemoglobin molecule. This can be, the value of the DLCO is decreased with an obstructive and or restrictive disorder. So it's not going to tease out obstructive versus restrictive, right? It's not going to say if it's low, it's obstructive, if it's high, it's restrictive. No, it doesn't do that. It can be decreased with either. But it gives us a quantification. It tells us a value, right? Fancy word for it. It tells us a value of the surface area destruction, how sick the surface area is in the lungs. We're going to use 0.3% carbon monoxide. We're going to use 0.3% carbon dioxide. Why do I make a big deal about this? This was actually a board exam question I got. What is the concentration of carbon monoxide used for a DLCO? It is 0.3%, not 3%, 0.3%. They were trying to get me there. They also use a mix of helium, oxygen, of course at least 21%, and the rest of it is nitrogen in there. So you're going to see a tank that's like brown. It has all these colors on it. It doesn't have all those colors on it because it's pretty. It has all those colors on it because it's marking the color for carbon monoxide, helium, oxygen, and nitrogen on it. A normal value, notice this is in bold, is 25 mLs of carbon monoxide per minute per millimeter of mercury. Normal value is 25 mLs of carbon monoxide per minute per millimeter of mercury. A normal value is 25 mLs of carbon monoxide per minute per millimeter of mercury. Why do I do that? Because this was also a board exam question. Right? This is something they'll ask you about. What's a normal value? And then, hey, there you go. And sometimes they might even just be like, what's the units for this? All right. A low DLCO. So what does it mean? Why do I care? If the value is low, it could be a volume restriction, like an interstitial lung disease like pulmonary fibrosis is going on. So if I do a pulmonary function test, and I have low volumes, right? I have low volumes and I have low DLCO, then that might be an interstitial lung disease of some sort. And there's over 200 different types of those, okay? When we're looking at a DLCO that's low, and they have decreased flow rate, so this one would be decreased flow rate and a low DLCO, then we're probably looking at emphysema. This is the only thing that teases out emphysema from the other obstructive diseases on pulmonary function testing. I'll repeat that again. This is the only test that confirms emphysema in pulmonary function testing because the flow rates are going to be low in emphysema, asthma, chronic bronchitis, bronchiectasis, so on and so forth. The only thing that shows that destruction of the surface area is the DLCO. So if the DLCO is low and the flows are low, we know it's most likely emphysema. What would the DLCO be with someone that has asthma? Well, remember there's a lot of inflammation, blood flow, so the DLCO could actually be normal or increased in some of those cases. So there's two methods of a DLCO test. There's the steady state test where they keep breathing until they reach a certain concentration that doesn't change, or the single breath, and this is the most common one that you guys will see out there. They use that 0.3% helium and 21% with nitrogen on a breath hold. So they take one breath in, they hold it for about 10 seconds, and then at the end of 10 seconds, they exhale. The first liter of gas that they exhale, we actually throw out. We get rid of it because it's going to be mixed gas with your mouth and oral pharynx and trachea. It's not going to represent your respiratory zone. It represents more of your conducting zone. And then we're going to measure the rest of it. And we're going to look at the difference between the carbon monoxide we gave the patient, which was 0.3%, and then the concentration that they exhaled. If we gave them 0.3% and they exhaled 0.29, then we know that hardly any of it got diffused into their system. But if we gave them 0.3% and they exhaled 0.01, then there's a big rate of diffusion there, and their AC membrane is very healthy in that situation. So this is what we're looking at. We have a small amount. They breathe in. They hold it to allow that gas to go all the way down into their respiratory zone. Most of it should get into the blood and bind with the hemoglobin because, man, that is what it loves. And then they exhale. And then we're going to look at the concentration of the exhaled carbon monoxide and then compare it to what we gave them. And that's how we know. So things that will cause the DLCO to change: if the patient position, if they're laying supine, it will actually be an increase because of the VQ match athletes. Absolutely. If they have a lot of red blood cells, left to right shunt going on, so that's a good blood to bad blood side. So it's the left side, right, the oxygenated blood going over to the right side. So like if they had a patent foramen ovale where the left atria, here let me draw the square heart. If there's a hole in between the left and right atria, obviously pressure should be higher on the left than the right. So this would be a left to right shunt. In this situation, there's going to be more blood flow that ultimately goes into the right ventricle, that ultimately goes into the pulmonary artery. which then goes to the lungs. So there's more blood that's like backed up into the lungs. So therefore, we're going to have more blood flow through the lungs, and therefore that's going to increase the DLCO because there's more hemoglobin in the lungs. Asthma, we talked about that, where there's more inflammation and swelling that's going on in your lungs with asthma, so that would be an increased. DAH is diffuse alveolar hemorrhaging. And we'll talk about that one later, but diffuse alveolar hemorrhaging, you're literally hemorrhaging into your alveoli. So there's more red blood cells and hemoglobin that are actually bleeding into your respiratory zone, and therefore more hemoglobin available, it would increase your DLCO. Well, what decreases your DLCO? Emphysema, we already talked about that destruction of the respiratory zone, all these areas that just get like Swiss cheese and just destroyed. Pulmonary fibrosis, if we have a really thick AC membrane, it makes it really tough to get through there. A pneumonectomy, if they have like a lung tumor removed from a non-small cell lung cancer. Obesity would decrease the DLCO as well because there's less surface area overall because the lungs are getting squished, restrictive. Pulmonary hypertension would decrease it as well because in this case the pulmonary hypertension isn't because there's a lot of blood, it's because the blood vessel got really skinny and there's less hemoglobin moving through the AC membrane. So if that capillary is really skinny, we're not going to have a lot of hemoglobin to pull off the carbon monoxide from the lung. Multiple pulmonary emboli, that's where we have a blockage, right? There's a big blood clot that's sort of stopping it from going in there. So that means there's less hemoglobin going past the AC membrane, therefore picking up less of it. And then bronchiolitis obliterans, also that's going to be a necrotizing issue where it's pretty much destroying like what we see with emphysema. Okay, MVV, this is a different type of test. This is the volume of gas that is exhaled during rapid and forced breathing. So this one's fun. So you're going to breathe really deep and really fast for about 15 seconds, right? Pause it and try it, but make sure you're sitting down. Right, really fast, really deep, move as much air as possible in and out as you can. We need to do this at least twice, so make sure they don't pass out, make sure they recover, and then go ahead and try it again. But we need to do it at least twice. The two largest, should be within 10% of each other. If not, then you're going to have to do a third test, which I can tell you how excited the patients are to do this one. Adult patients tend not to enjoy this test too much, but this is, you have them breathe as fast and as deep as you can, right, as deep and as fast as you can as into the spirometer. All right, and we're trying to see what's their maximum amount of ventilation they can get out. And this is what it looks like. They're breathing normally, and then they breathe rapid and deep, and then hopefully they recover afterwards and they don't pass out. So 12 seconds, right, around 12 seconds, how much gas can they move? And this looks at overall lung function status. So if they're restrictive, it will be small. If they're obstructive, it will be small. If they're combined, the MVV will be small. But if it's normal, it tells us overall their lung function is doing okay. Okay, so it's a great test for overall lung function. And then if it's low, then we need to look at effort. So how do I know someone gave me good effort on this test? Well, if I take their FEV1 times 35, I can get what's predicted for their MVV. So their predicted MVV is FEV1 times 35. Okay, so if I do the MVV and it's lower than what is predicted by a significant amount, then I know that their effort on the MVV was poor. Well, what if I did an MVV and I divided it by 35. So if I take the MVV, divided it by 35, and I get a higher FEV1 when I do this than what I actually got when I measured it earlier. Well, that would then mean that my FEV1 did not have good effort, and I need to go back and redo my FEV1. This is something they test you on the board exams. That's why I'm going through it. So you need to know how to predict an MVV, FEV1 times 35, or to look at their predicted, and then you can take MVV divided by 35 to look at their effort for their FEV1. If their FEV1 is smaller than what you get on the FEV, or smaller, so if their FEV1 is smaller than what you get on the MVV divided by 35, then that's a sign you need to go back and repeat the FEV1 because their effort originally was not strong enough there. Isn't that crazy? All right, overall function of the respiratory system. You can't say I didn't make this a big point. All right, this is influenced by airway resistance, how strong your respiratory muscles are, the compliance of your lung and chest wall, how well your ventilatory control mechanisms are in your brain, right? If you have a glioblastoma meningioma, like a brain tumor, right, this can really affect the MVV, and it can tell us overall how it's affecting the patient. Your MVV decreases with age. Everybody say boo. Boo! Decreases with moderate to severe obstruction. It can be normal in some restrictive disease because they're breathing faster, but the whole thing here is it depends on effort and cooperation. And that's why we have to calculate that times 35 or divided by 35 to look at effort as well. All right, so when we're looking at volume test versus flow test, I told you need to look at the difference between the two. Volume test, we can use direct spirometry, which looks at vital capacity, inspiratory capacity, inspiratory reserve volume, tidal volume, ERV, force vital time. Or we can do indirect spirometry, right, where we see and calculate their residual volume, their FRC, and their TLC. So these things cannot be directly measured. That's why they're indirect. They cannot be directly measured. In fact, they're just calculated from subtracting. So if I take someone's total lung capacity, so if I put someone in a body box and I do a vital capacity minus their total lung capacity, it will give me their residual volume, right? So these are calculated. They're not usually measured, directly measured with how we do it. Obstructives or low flow, we can look at their FEV 1%. Remember, this was a big key point that we talked about earlier. We also like looking at their medium to small airways. We like looking at their flow volume loops, and I showed you that flow volume loop where it actually gave us a peak expiratory flow rate, which was that down part of that curve. Remember the curve, and then sometimes it has that scoop in it. If you go back and look. Hopefully that picture sort of renders something. Vmax 50, how fast they blow out. So we're looking at flow rates and then volumes. You need to know which volumes we can directly measure and which ones are indirectly measured, volumes, capacities. All right, this is the flow volume loops that you might see with different disease condition. This one will come in very handy. Asthma, we talked about this over here. They'll exhale really, their exhalation is very poor, so their peak expiratory flow rate is very low. And also you see the scooping here compared to the normal. That scooping is a big sign. Just like the emphysema, where you could really see that scoop in there big time, is a sign of that small airway obstruction. And then the inspiratory, their peak inspiratory flow rate is usually decreased as well, because there's something obstructing their airways, both inhale and exhale. Same thing with emphysema, something's obstructing their airways, both inhale and exhale, and that's why you see it smaller than what you see with the predicted for them. Restrictive effect, volume is your x-axis, right? So you're going to see a lot smaller volume than what is predicted for them overall. But it's going to mirror what it would be. It just looks like a mini-me. It's a smaller one. Intrathoracic obstruction and extrathoracic obstruction, we're looking at something that's blocking the ability for them to exhale or inhale, or fixed obstruction like a tumor in their trachea. We're going to see these different values. We're going to see these different waveforms as well. All right, so hopefully go through this slowly. Like I said, separate the different tests, the indications, what they measure. Go through practicing interpreting some of those like we did with restrictive, obstructive, or combined when I give you those values. Practice the best test situation where you had to pull the best number for the FVC, the best number for the FEV1, and then you had to calculate separately those two numbers, what their FEV1% was. Then you had to calculate which of the three tests, which one of those had the best flow rates, which one of those had the best flow rates to use. Remember, you'd use the sum of the FEV1, FVC, and the flow rates from that one we're going to use for the best test. So be sure to practice this stuff, go through it, don't take it lightly, make sure to read your material as well.